Good morning. Welcome to the webinar, Data You Can Use, Accessing Online Statistics for Childhood Cancer Incidence in Pennsylvania and Neck Cancer Survival in Pennsylvania. This webinar is presented by the Data Advisory Committee, which is a committee of the Pennsylvania Cancer Advisory Board. Today's presenters are Dr. Richard Aplenitz, Professor of Pediatrics and Pediatric Oncologist for Children's Hospital of Philadelphia, Ellen Flegel, Statistical Analyst Supervisor for the Pennsylvania Department of Health, Nathan Worth, Statistical Analyst for the Department of Health. I'm the moderator, Joanna Stoms, and I'm the Cancer Plan Manager and Data Advisory Committee Co-Chair for the Pennsylvania Department of Health. A few housekeeping details today. All attendees will be muted during the presentation. Any questions can be typed in the chat box in your toolbox. If time allows, we will answer questions after each of the presentations. All questions will be answered in writing and will be emailed to participants. And a copy of today's presentation is available in your handouts section. Just a disclaimer that funding for this webinar was made possible in part by the Centers for Disease Control and Prevention. And the views expressed in written conference materials and publication and by speakers and moderators do not necessarily reflect the official policies of the Department of Health of Human Services or the U.S. government. I'd like to offer a special thank you to the Northeast region of the American Cancer Society for hosting this webinar from beautiful downtown Hershey, Pennsylvania. So we thank them for the ability to use their resources at this time. And at this point, I'd like to introduce Dr. Richard Aplenitz, a pediatric oncologist for the Children's Hospital of Pennsylvania and a professor of pediatrics at the University of Pennsylvania. Dr. Aplenitz was also named the Chief Clinical Research Officer for CHOP. He will be a consultant for today's webinar and will be providing a few opening remarks. Dr. Aplenitz?
Thank you very much for that introduction and for asking me to be a part of this panel, which I'm very excited to do. Obviously, as a pediatric oncologist, I think this is the most important topic in the world, but I also understand that I'm a little bit biased. But it is true that pediatric cancer is actually one of the leading causes of death in children in the United States, and causes a substantial amount of burden on the healthcare system, and as well as on patients and families. And I think that some of the information that hopefully, or that you will see later on in this webinar is, for me personally, very exciting, really specifically being able to drill down on cancer incidence across the state of Pennsylvania and being able to manipulate some of that data, I think personally is very interesting and exciting. And I think that's a great service to those of us in the pediatric oncology world who are really interested in understanding what are some of the causes and outcomes for kids with cancer in Pennsylvania. So I'll just say very briefly that there's a lot of research that's happened on the causes of cancer in children. Probably 10% of kids with cancer have an underlying genetic predisposition to cancer, but for the other 90%, we don't have a clear genetic understanding for why they were at risk for developing cancer. There's a lot of work going on to try to understand the environmental exposures that could change someone's cancer risk as a child. And for me, that's personally one of the things that's very exciting about these data, and that I hope that they will help us to get a better understanding of those risks for kids here in Pennsylvania. The treatment for kids with cancer is really varied by the type of cancer. And I think generally you could separate cancers in children into cancers of the blood and the lymphatic system called leukemia and lymphoma, tumors of the central nervous system, we typically call those brain tumors, and then other solid tumors. And the treatments for those vary. Many of them involve chemotherapy, either by mouth or through the IV. Some of the cancers also require radiation therapy, and some also require surgery for cure. And the cure rates really vary very much by type of cancer. There are some cancers where we can confidently tell a newly diagnosed family that their child has a upwards of 98% chance of being cured with fairly low chance of long-term side effects, while there are at least a couple cancers where the first conversation we will have with a family is to say that their child has an incurable cancer and will die of their cancer, in the next couple years. So there's a really broad range of treatment experiences and outcomes. But I would say that in general, we can cure about 80 to 85% of children. And although some of those children will go on to develop long-term side effects, such as cardiac issues or issues with growth delay or obesity or diabetes or other medical complications, many of those can be managed effectively. There are some very new and exciting therapies that are being developed here and elsewhere. You probably have heard about the dramatic impact that the immunotherapy treatments have had on kids with acute lymphoblastic leukemia, and there's a wide range of other immunotherapy and targeted molecular therapies that are being tested and evaluated now in children, and we're hopeful that those will help us cure some of the kids who at this time can't be cured with standard therapies. I think that's sort of the general overview that I would present, and certainly at the end of the presentation, if there are any questions or other background information that people would like to have, I'd be glad to try to answer that either on the phone or in a written form. But I want to make sure that we have enough time to talk about the data resource, because I think that's actually the really exciting and really the focus of the webinar.
Thank you, Dr. Aplins, for that very informative overview. And now I would like to introduce Alan Flegel, Statistical Analysis Supervisor for Pennsylvania Department of Health, who will discuss how to access online statistics for childhood cancer incidence on the Pennsylvania Department of Health Health Statistics website. So, Alan, take it away.
Thank you, Joanna. So my demonstration today will be focusing mostly on an online tool that the health department has on their website. We're going to focus on childhood cancers today, but you can pull out a lot of other data from this system. And we're going to show you how to create tables, charts, and maps using this system. Just a brief outline, our data system that I'm talking about is called EDDI. And I'll show you how to access some of the different help files in there. We'll talk a little bit about the primary site definitions that are used for childhood cancer, and move on to tables and charts and maps, and conclude with a few highlights for Pennsylvania. So the EDDI system stands for Enterprise Data Dissemination Informatics Exchange. So remember that, because there will be a test at the end. And what this is it's a department's primary tool for data dissemination. I think we have at least 19 different data sets in there currently, and you can really customize the tables or charts or maps that you're trying to look at by making menu-driven selections in this tool. It was released in January of 2016, so it's about 2 years old. And for anyone who's been to our website in past years, this has replaced an older system that was known as EpiQMS. So the first thing is, how do you access this tool? And you would want to go out to our statistics website. I have the address on this slide here. It's statistics.health.pa.gov. And when you come to our page, you'll see it may have some updates that aren't shown here, but it'll be similar to this page here. And you can select EDDI from different menus. There's menus across the top. There's a side menu over here. Under our quick stats, there's also a way to get EDDI. So it won't be hard once you get to our statistical area to be able to find the links that get you connected to the right locations. So when you come to the welcome page, you'll see a screen that looks like this, And I just want to bring to your attention the links that I have circled in red here. These would be like frequently asked questions on EDDI. We have a few tutorial videos that actually demonstrate how to do some of the things that I'll be talking about today. And we also have printable instructions. So when you come to this welcome page, you will actually want to click on the logo, or I think the title up here will also get you started. And you'll come to a screen. The initial screen will look like this with 4 different menus. And this is basically where you're selecting the different data that you want to look at. We're going to be focused on childhood cancer, but like I had mentioned earlier, there's 19 different data sets in here, from sexually transmitted to diseases. We have a more detailed cancer incidence data set in here. There's birth data. There's also risk factor data. And we try to expand upon this as time goes by, and we find out that different offices want to share data through the Department of Health. This is going to be their primary tool for doing so. So I'm choosing childhood cancer data, and in the third menu, you would choose a different geographies, different data sets. Typically have county and state data. Some may have regional, district, or even municipality level data, depending on what you're looking at. And in the fourth section here, you will tell the system, do you want to look at a table, a chart, or a map? And again, different data sets are going to have different options there. Some may not have a chart or map set up at this time. I believe everyone does at least have a table they can work through. And you would click the next menu to get to the next set of screens. I'll just point out this reset selections here would reset all your selections. You'll see this on some of the other screens too. And we also have help files built into all the headings of each of these menus. So if you're not sure what one of these menus is, there's a help file that I could click on to bring up help information on that. So this is the creating a table screen that you would see for childhood cancer. Each of these menus also has a help file associated with it. So we have a primary site is the unique feature in this childhood cancer data, and these are based on classifications that are used very specific for childhood cancers. They're the International Classification of Childhood Cancers definitions. They're not necessarily suitable for like mortality data, but they're very specific and good with the incidence data for cancers that are more likely to affect children. So we currently have 12 different cancer sites in there. I'll mention quickly on the other menus. We have the county and state data. You can make multiple selections in here. Our data is limited to 5-year periods, and that's mainly because a lot of times the data are very rare for childhood cancer, so we're dealing with very small numbers. And then you can select the gender or race data. And we also have 2 different rates you can pull out. You can pull out age-adjusted rates or crude rates, and these are always accompanied by frequency counts as well. Just take a closer look at the primary sites here. These are going to be things like leukemias, lymphomas, different brain cancers. These are the sites that are most common among children, and that's what we have the system set up to pull out. Again, there would be help menus for all these items. You can click on any of the titles and pull up a help file to get more information on how actually we define some of these primary sites, for example. Once you would make your selections with these menus to what you're looking for, and again, I said you can make multiple selections in here if needed. You would hit the Create Table button, or if you need to reset something, you can reset them as well. And once you create the table, you'll get output that looks very similar to this screen. In this case, we were looking at all cancers and some, I think it was malignant bone tumors as well. And again, each of these headings on this table here, you can sort any of these either numerically or alphabetically by using the arrows. and you can also bring up a help file associated with any one of these columns that are shown here. One of the features we have is being able to export the data. So if you'd like to save some of this to your computer or use it elsewhere, you can select this little diskette up here. And we have Word, Excel, PDF. A TIFF file is like a type of image you can save. And the CSV file it actually works better than the Excel output that we have if you need to manipulate the data or do something like create a chart later on with the data or want to do something with Excel. I kind of recommend the CSV as being one of the more popular ones. You can also do pipe delimited. So we give you a few different options for saving that table. And I have an example here of someone, if you were to click on age-adjusted rate here to bring up the help file. Help files are typically like a pop-up message like this, and it will tell you a little bit about information about what this rate represents in this case. Important note here on this help file is that if you were looking at county level data and you had red or blue rates, those would be significantly different. And we also have links going to our tools of trade articles that might give you a little bit more information too on rates and ratios. So each one of the columns in there would have a help file that in case you had questions about it. I also want to point out, you'll see a breadcrumb trail typically in this area of EDDI, which tells you what selections we had made on the previous menus. When there was 4 menus earlier, we had selected table. In this screen, we've switched over to the chart module. So it's telling us that we looked at childhood cancers, we selected county, state for our geography, and are now looking at chart options. It's pretty similar to the table. We have our primary sites, county, year, sex, race, and different rates you can choose in here. But we also have some chart options over in this area. And right now the system is set up to do 2 different types of charts. You can look at a vertical bar or a trend line. And you can choose to show the table below the chart, or you can not show that if you wish. This is an example of once I hit the create chart button, I would get a bar chart. So this is an example of one where I was looking at leukemias in this example, and you can see that there could be a slight increase in trend here. We're not exactly sure why, and we're comparing Pennsylvania to Philadelphia in the red bars, so you can see that the rates appear to be somewhat lower in Philadelphia. And again, you can also export this chart. Maybe you want to save this chart for other purposes, so you can go up to this little diskette, and again, you have the same options that we saw with the table to be able to export that data. This is an example of a line chart that I created, basically using the same options. Again, we were comparing leukemias for children, and we were looking at Pennsylvania compared to Philadelphia. The red line represents Philadelphia. You can see there appears to be a slight increase over the years, possibly for Pennsylvania. And Philadelphia really didn't have too many increases except for the most recent year period, which was 2010 through 2014. If you were to hover over a data point in any of these line charts, you actually can see what the data is there in its confidence interval. Of course, you would also see that if you had a table below the chart. This last screen demonstrates the mapping capabilities in EDDI. Again, it's very similar to the other menu selections we had seen so far. They have a map and settings area over on the right-hand side. And this is going to allow you to change some of the ways you output your data. I usually just keep it on optimal, but you could also, when you create a map, you often get a range of data or different colors that are going to show up. You can choose to do equal interval or equal distribution. There is a little bit more information explaining those features in the help file. So if you would click on map settings and you wanted to read about that, you could do so. Once your selections were made in here, though, you could go in and hit the create map button. And this is a screenshot of what those maps look like. The darker shaded areas are going to represent higher rates in these particular counties. The gray shaded areas in here are, even though this is 5 years worth of data summarized here, the lighter shades would represent areas where we didn't have enough frequency counts to be able to show those counties. Again, if you hover over a particular county, in this case I hover over Tioga County, I can see what the rate is in the confidence interval. And there's also information in your title above that map as well. In this area, we have the ranges I was talking about. These were created using the optimal ranges where it tries to best fit the data into these particular ones. You could have done equal intervals or equal distribution as well. And you can see there was quite a variety here. The lowest rate was 15 and went as high as 36 in some of these areas. In some of these areas, it is important to look at confidence intervals. And when I looked at some of the higher rates here of childhood cancer, they did appear to be in some of the more remote counties. So there still may have been a low frequency count there, but when they calculate the rates, they did get a higher rate. Just a few summary points that I put together on these last couple slides. According to the American Cancer Society, childhood cancers make up less than 1% of all cancers diagnosed each year. So this is a very rare cancer, and that's why we show 5-year periods of data. Childhood cancers are also very difficult to try to prevent. A lot of this is because they're often not linked with lifestyle or environmental risks like we see with adults. If you can imagine, these children are often very young, so they haven't had the time to be experienced to a lot of lifestyle risks or environmental risks. Some smokers, for example, among adults can smoke for a number of years, and it takes a long time for the cancers to develop. So that makes it very difficult to try to come up with ways to prevent childhood cancer. This was a comparison. I pulled out some data from our EDDI system for childhood for the 12 different cancer types that often show up, and I compared them to the US data to see what kind of comparison that would give us. And you can see it, for the most part, we have some small changes, but they're pretty much on par and they're very comparable to what we're seeing nationally. I used data from the National Cancer Institute's SEER program to represent the United States, and we really only saw small differences among the rates. Some of the ones down here were a little bit bigger for the other categories, but I thought that may be because we had a small frequency count. And sometimes we weren't even able to calculate a rate for this last 12th category because the numbers were so low for that particular year. Looking at gender differences, I tried to pull out the largest ones I could find in our system at the state level. And we saw that males have slightly higher rates for leukemias, lymphomas, and brain cancers. Those are some of the more common sites that we see among children. When I looked at the other malignant epithelial neoplasms, I did see a higher rate among females. We also looked at a similar chart for racial differences. It just happened to be at the largest differences were among those same cancer types that we looked at by gender. In these examples, it seemed to be a little bit higher among whites for all 4 of these, especially this last other category. Again, I might put a warning on this last category that it's based on very few cancer cases. I don't have the frequency counts right in front of me right now, but sometimes it's important to look at the confidence intervals to get a sense of how much difference there may be here. That wraps up the EDDI presentation for childhood cancer statistics. Again, this is our website and some of our contact information if you guys would like to reach out to us with further questions.
Thank you, Alan. Thank you for that very informative presentation. We'll open it up for a few questions here. We do have one in the chat box, and this question is directed to Alan, and it is it possible to get a breakdown, excuse me, of age groups less than 20, such as 0 to 4, 5 to 9, 10 to 14, etc.?
Yes, it is, but you can't do it through the childhood cancer data set that I have here. So there's 12 sites we have. You would have to find a similar site in our main cancer incidence data, and you would want to break it out by crude rates in there. Once you, a lot of people don't realize this, but in our cancer incidence data set, which includes adults and all ages 0 and older, if you choose a rate and switch it over from age-adjusted rate to crude rates, you'll see a large number of age groups that you can choose from. You can choose under 1, 1 to 4, 4 to 9, and basically like those 5-year age group periods there. You can pull out data like that. If you're unable to find that, of course, you could always reach out to us, and I'd be glad to help folks find that information in there. The primary sites that we use in our main cancer incidence data are a little bit different than these ones we use for childhood cancer, but they still would be appropriate to do this kind of analysis, and they would match up better with our death data as well too. So you could pull out things like lymphomas, brain cancers, and also leukemias, which are common among children. There may be some of those sites that don't match up quite as well, but I still think there's a lot of information that you could pull out there if you wanted to look at the age breakouts under 20.
Thank you, Alan. We have another question. Does the chart versus US SEER get generated within EDDI? And if yes, is it possible to generate a chart with 3 bars, specific county, all of Pennsylvania, and US SEER?
And right now, I did not prepare that particular chart because I needed US data. I needed to prepare that chart on my own. Right now, the charting options are pretty basic in EDDI. It's just to give you an idea, is there a trend going on, or maybe to do a few simple comparisons. I think when you get into the chart options in EDDI, you'll find that sometimes you can't do as many multiple selections. I think you can often do the year menu as multiple selections in EDDI, but you may find that there are sometimes some limitations in there. The idea is just meant to give you a few basic charting options. If something more detailed needs to be done, then what I would recommend is working with the table module and exporting your data into a different software, perhaps Excel or something else that could do those type of charts.
Dr. Aplin, before we move on to the next part of the webinar, do you have any other comments?
No, I'm sorry, I did not. But thank you very much for inviting me to participate.
Okay, thank you very much, and thank you, Alan.
Another thing worth mentioning about our childhood cancer data is the rates are per 100,000. Some other sites, especially national, you may see it, they post their sites per 1 million. So that difference has to be accounted for if you're doing comparisons with US data, and to pay attention to details like that. Thank you, Joanna.
Thanks. So in part 2 of our webinar, we featured the Neck Cancer Survival in Pennsylvania report, which is also available on our Pennsylvania Health Statistics website. One of the authors of this report is Nathan Wirth, and Nathan is a statistical analyst for the Pennsylvania Department of Health. He and Alan work together. Nathan will provide an analysis of the data, and I will discuss how the neck cancer survival data was used in Pennsylvania cancer control programming and planning. So Nathan?
Thank you. So the goal for this part of the webinar is to let you know about our neck cancer survival report and provide some ideas for using the data. So what is net survival? Basic survival is an invaluable measure for public health, showing the hazard of death throughout time. This hazard varies depending on a person's age, race, and sex. So with this report, we wanted to look at the hazard just related to cancer. So we use net survival rates. With this definition from POHAR-PERM, net cancer survival would show these hazards in a world without non-cancer causes of death. So to remove background risks, which are those not related to cancer, we use life tables based on death certificate. These are the same kind of tables used to estimate life expectancy. We created tables for different groups of Pennsylvanians based on covariates which influence a person's risk of death: age, sex, race, and calendar year. By matching each cancer patient to his or her respective life table, the background risk is theoretically removed. But net survival is more complicated than what's called the cause-specific method. With cause-specific, we would do a normal survival analysis, but just reclassify every non-cancer cause of death as not death. But unfortunately, studies in the past have shown inaccuracies in listed causes on death certificates. Sometimes codes are vague. Sometimes they just decide to go with a larger site instead of the actual site. So because of that, this national standard for survival with survival analysis of cancer is to use net survival. So the reason to use it is because it singles out a cancer's death risk, and it lets us compare outcomes by screening or treatment. So while differences in screening can lead to something called lead time bias, which I'll explain later, we can still make useful comparisons. And our analysis this year did not cover treatment, but is to be considered for the future. So the online report. All the statistics in this webinar and more are available in a new online report, which you can find at the Department of Health Statistics website, which is statistics.health.pa.gov. The full link right to the report is on this slide. The report compares net survival between cancer sites, races, ages, and years of diagnosis. All the data shown is available for download in the report. So let's look at a few of the more interesting results from our analysis. But first, the context for the data. All these cases are for the Pennsylvania Cancer Registry. We only looked at Pennsylvanians between age 15 and 99 when diagnosed. A tumor among this group was included only if it was A, the first malignant tumor for the patient, B, invasive, and C, diagnosed before the day of the patient's death. So to estimate current net survival rates, we pooled recent diagnoses from 2007 to 2013. To do trend analysis, we grouped the cancers by individual years of diagnosis. So for the trend analysis, trends in net survival, they're a great way to judge the overall progress of cancer control efforts. With statistical analysis, you can also use them to compare risks before and after a specific policy or program takes effect. So in Pennsylvania, the most commonly diagnosed cancers are those of the breast, lung and bronchus, prostate, and colon and rectum. So this chart shows their overall trends in 5-year net survival rates between 2001 and 2009. We could only go up to 2009 because we needed 5 years after that and an extra year's buffer time for the analysis. So the rate for prostate cancer did not significantly change, but it remained just below 100% over the period, so there was little room for improvement. Similarly, the breast cancer survival rate held steady. Most of these cases are caught at a localized stage, which also has near 100% net survival. Net colorectal cancer survival also kept level for the period, though it was always well below 100%, even by stage. So lung and bronchus cancer was the only one of the big four to see an increase in net 5-year survival. So the rate for localized diagnoses went from 51.6 to 60%, and the regional diagnoses rate went from 19.1 to 29.7%, which is large increases. So early detection of cancer can improve outcomes. Everyone knows this, but it can also introduce what is known as a lead time bias in net survival. Detecting a cancer 1 year earlier means 1 more year of survival past diagnosis, which is what we're measuring. So we can avoid this problem by looking far enough out from the diagnosis year that the net survival, so that the net survival rates level off. For both prostate and cervical cancer shown here, 5 years seemed to be enough time for this to happen. So again, these statistics are based on cancers diagnosed between 2007 and 2013. The 5-year net prostate cancer survival rate was low for distant stage, indistinguishable from 100% for regional stage, and over 100% for localized stage. To interpret this, this means men diagnosed with localized prostate cancer had a higher life expectancy than the general population. The life tables control for differences by sex, age, and race, so these patients had something else in common that improved this. What it was, we don't yet know. For cervical cancer, the differences between a localized and regional stage diagnoses, they're wider. Localized diagnoses have a 5-year net survival rate of 88.6%, but that drops to 56.4% for regional and 13.2% for distance. And I included it here because cervical cancer is one of those that, relatively to other cancers, it's easy to screen and not too hard to treat. So this is something that we could improve on. Our analysis also looked at groups of patients by primary payer at time of diagnosis, which I just simplified and called insurer. We classified them by their insurance stances at the time, and here insured includes insured groups, private insurance, and Medicare together. So as we would expect, patients with private insurance or Medicare, they have the best outcomes. And this chart shows net survival as time progresses after diagnosis. So, but those who had Medicare, they fared better than the uninsured during the first year of after diagnosis, but ended up having worse net survival after 5 years after diagnosis. This is despite the rates being age adjusted. There were differences in distribution by age, but we do age adjust our survival rates. And the Medicaid group actually had a higher proportion of early diagnoses than the uninsured. So we don't know what's causing this yet. For the rest of what we found, please look through our report. Again, the website is statistics.health.pa.gov. If you search net cancer survival on the homepage, it should be the first result. And now Joanna Stahms will illustrate how our cancer control program has used net survival data.
Thanks, Nathan. So in this section, I'm going to talk a little bit about how our cancer control programs here in Pennsylvania use the data to plan and implement their activities. So the Livestrong and the Healthy Woman program. The Healthy Woman program is Pennsylvania's breast and cervical cancer early detection program. And what they did is they used the net cancer survival data by county to determine where they were going to focus their activities to expand the Livestrong at the YMCA program. Livestrong at the Y is an evidence-based program which aims to increase the health and well-being of cancer survivors. So it provides physical activity for cancer survivors, professional trainers, and it is generally low or no cost for cancer survivors. But which locations? So what we did is we looked at the net cancer survival by geographic area, which is a map of the counties. And we did find that Philadelphia County was particularly lower than the state average in net cancer survival rates for breast cancer. So we decided to focus our efforts to expand the Livestrong at the Y programs in Philadelphia County and provided funding to do just that in those regions. Another example of using the net cancer survival data in cancer program planning was in lung cancer control. The Pennsylvania Comprehensive Cancer Control Program examined net lung cancer survival by county, prevalence of smokers by county, and home radon levels by county. And what we did find is that the northern tier, particularly in Pennsylvania, was really low in survival, but high for smoking and radon levels. So the northern tier of Pennsylvania and some of the rural counties in southwest Pennsylvania were particularly affected by these issues. So this map shows net lung cancer survival by county. So you can see that the northern tier, really kind of all throughout Pennsylvania, but primarily in that northern tier, a little bit of, I would say, western Pennsylvania to central western Pennsylvania, and southwestern Pennsylvania. These counties are served primarily by critical access hospitals and rural health clinics. So we decided to focus our efforts, our lung cancer control efforts, on working with these critical access hospitals through the Pennsylvania Office of Rural Health to address really tobacco cessation efforts, to increase those, to increase awareness around radon reduction and prevention, and to increase awareness about lung cancer screening. So that's how we used neck cancer survival in lung cancer control. So that really wraps up the portion of neck cancer survival in Pennsylvania. And at this point, we'll open it up to any questions that you might have. So I'll have you type them in the chat box.
So the one question we got before the webinar was, the data always seems to have a lag time of at least 3 years. With the advent of modern technology and the potential of being in real time, why does the lag occur? Do other states have the same lag? How can we improve the report out stats? So for the answer, having data available within 24 months, which is what we do now, that's the national data quality standard, which is set by the National Program of Cancer Registries. And NACER, which is the North American Association of Central Cancer Registries, has a very similar standard. So why 24 months? Hospitals have 180 days after a patient's discharged from their hospital to submit the case to the registry. We also collect cases from non-hospital facilities, which often require someone in the registry to actually call and reach out. After that, quality assurance procedures are done to ensure all cases are reported by every single facility that needs to. After all these cases are received, the registry then processes and consolidates the records, and that's an ongoing process. The records are then matched against national death certificate databases to get the most recent information. And finally, a statistical review is done for the last step of quality control. The registry receives over 120,000 cases a year that get consolidated into about 80,000 incident cases. And while most of this process has been automated, there are still situations that require a staff person to review and judge what needs to be done.
Thanks, Nathan. We do have a question from one of the attendees. It asks, are there any Livestrong locations in Pittsburgh or Western Pennsylvania? And if so, how does this location differ to the Philadelphia location? I believe there's Livestrong locations all throughout Pennsylvania. Where specifically, I'm not sure. I think if you would go on the Livestrong at the Y website, you would see the locations within Pennsylvania. I'm pretty sure that there are some Livestrong locations out in Pittsburgh and Western Pennsylvania, and it would not differ than the Philadelphia location. All the Livestrong, when a Y agrees to become a Livestrong program, they go through some very specific training in order to become a Livestrong program. So I think what the goal here is in Pennsylvania is to try to expand or provide resources to help the Y expand those Livestrong programs so they're more available to cancer survivors throughout Pennsylvania. So we just used some of our funding to help expand in the Philadelphia area just because of the low breast cancer survival rates. There's another question. Will these slides be emailed to webinar participants? Yes, they will be. So you can expect that. Additionally, there's another question. Additionally, is there a way that researchers or scientists could add potential measures or counts to be considered for the EDDI databases or net survival registries? What is this likelihood? And I think I'm going to let Nathan or Alan take this one. You might have to take a look at this question.
A lot of times the data is very closely associated with its source data. So I mean it could potentially be possible, but usually we have to review what's available and what can potentially be done with the data source that we have and what measures could potentially be added. But we do have like what I would recommend if someone does have ideas is to just reach out to us. There's lots of contact information on our EDDI site. So if they did have ideas, we would we would respond to those ideas and evaluate to see if something like that would be possible. There's really a lot of different data sources that go out on our EDDI website, and some of them I'm more familiar with others. With the cancer and death data, I may be a little bit more familiar with those data sources. Some other ones may actually come from survey questions, and as you can imagine, the data sources are quite varied. But we would welcome any ideas like that, and I would recommend they just reach out to us if they had questions or would like to see certain measures or features on the EDDI system.
Thanks. Nathan, do you have anything to add?
For how do they phrase that, to add to the net survival database, or what? So
could have potential measures or counts to be considered for EDDI or the net survival registries.
Okay, the net survival analysis just used the Pennsylvania Cancer Registry, which is supposed to be, and by law it's very close to being, a complete collection of all reportable cases. So I would be kind of reluctant to use cases from any other source. If you mean that you would provide other things that I could judge net survival and compare it to, I would be very willing to do that. Any information that's useful to the users is something that I would like to have. So again, just go to our website and reach out to us and we can have a discussion about that.
I think I would also like to clarify that what we can report, or what we can pull out for reports, is really linked to what the source data provides us. And I think that's what Alan was trying to allude to, that we can't report, generally cannot report on data from the cancer registry that we don't get from the hospitals and the clinics. But there's always a possibility that we can report on data that we're not currently reporting on. So I would suggest that you reach out to myself or to Alan or to Nathan to see if we could possibly report on that data.
I think one of the reasons we actually added childhood cancer data set is because we occasionally get different inquiries at the Department of Health that would like to concern families or possibly even researchers. They might be interested in that type of data. So that's kind of how something like new data sets might, even if we get enough interest in things and there's a potential data source, we certainly would welcome those ideas and consideration for as we develop EDDI.
We have a question: where can I find a data dictionary or similar documentation for the Pennsylvania Cancer Registry data?
The Pennsylvania Cancer Registry data uses the NACER format, which is NAACCR. Again, that's the North American Association of Central Cancer Registries. And they have a data dictionary that you can reference. I reference it all the time, and it's very good. So if you get cancer record data, that's where you would figure out how to interpret it.
I would just add some items that are on the NACER data dictionary potentially could not be collected by the Pennsylvania Department of Health too. So they have a very detailed, so sometimes they might have to actually reach out to the registry or to the Vital Statistics Office to find out what exactly we collect. We may even collect a few additional state-specific items that are also not clearly defined on the NACER format. But in general, as Nathan said, the NACER format is the format that our database is stored in, and we would generally have those type of fields available. There may be some things we do not collect. We don't do active follow-up, which some NACER registries may do.
I would also like to let the participants know that we will provide the link for NACER when we email out the question and answer, so you'll have that available to reference. So we have a few more minutes. If there's not any more questions, we will probably go ahead and wrap this up.
Can I jump in?
Sure. Nathan has a few more comments.
This is a question I get in the department sometimes, so some of you may be wondering this and just nobody asked it. Can net survival be used to estimate actual survival chances for a specific patient? No. Net survival only shows risk of death added by the cancer diagnosis. The purpose is to assist in comparing between groups. It's not meant for individual patient use. I did.
no one has any more questions, I think we'll just say thank you for attending today's webinar. If you have any questions, my contact information is on the slide. You can always reach out to HealthStats through their website. And we're always, Nathan and Alan are part of our data advisory committee for cancer control. We're always interested in what our partners out in the field have a need for. So if you have a specific data request, feel free to reach out to us in regards to cancer control, and we'll see what we can do to address it. So in that context, I thank you very much for attending today's webinar, and we wish you a good day. Thank you.